So the question that we really asked ourselves was, is there value in routinely offering sentinel lymph node dissection to all patients with a preoperative diagnosis of EIN? And what we found is that in a large cohort of patients with EIN who underwent hysterectomy, so few patients had endometrial cancer with high-risk features on final pathology that offering a routine sentinel lymph node dissection, all patients with EIN would most likely result in overtreatment. In our study, we looked at 378 patients with a pre-op diagnosis of EIN that underwent hysterectomy in a 10-year period. And we found that only 27% of those patients had endometrial cancer on final pathology, all of which were endometrioid histology, with over 90% with grade 1 disease, 95% with stage 1A disease, and less than a third of those patients were considered high risk by Mayo criteria. Even after applying the Mayo criteria intraoperatively to guide our decision to pursue lymph node evaluation, no positive nodes were identified in this cohort, which really supports the argument against routine sentinel lymph node dissection in all patients. Given that in endometrial cancer, the alternative to sentinel lymph node evaluation is a full pelvic and para-aortic lymphadenectomy, which is in itself not without significant morbidity, we asked ourselves the question, is there some set of preoperative characteristics in patients with EIN that we can look at that can help us predict the presence of concurrent endometrial cancer on final pathology? And then can we use that to selectively decide who might benefit the most from sentinel lymph node dissection at the time of hysterectomy? And what we found is that a preoperative endometrial stripe greater than or equal to 20 millimeters doubled the risk of endometrial cancer on final pathology, and that a preoperative endometrial stripe greater than or equal to 15 millimeters was significantly associated with meeting high risk Mayo criteria on final pathology. So this sort of suggests that although, routine sentinel lymph node dissection in all patients with EIN would result in overtreatment, we might be able to consider using a preoperative endometrial thickness as a criterion for selectively using a sentinel lymph node algorithm in this population. And this might be particularly useful in those patients who are at greatest risk from a full lymphadenectomy, including those at high risk of lymphedema, such as morbidly obese patients or those with prior pelvic or lower extremity surgery.